Let's move forward with enthusiasm and commitment to learn, share, and grow. Now it's time to move to our learning sessions. I invite Dr. Daivat Vaishnav sir, who is an expert in robotic surgery and laparoscopic gastro and pancreatic surgery from Ahmedabad, who will be talking about pancreatic surgery, journey from open to robotics.
Good evening, everybody. At the outset, I would like to thank Surat IMA અને સ્પેશિયલી વિનેશભાઈ, તમારી શૈલીમાં બધાને જગાડી દીધા તમે, એટલે બહુ સારું કર્યું. કારણ કે ઇટ ઇઝ ઓલવેઝ ટુ પ્લેઝર ટુ કમ બેક ટુ ધ આલ્મા મેટર. કારણ કે હું અડધો હુરતી જ કહેવાઉં, કારણ કે 12મા ધોરણમાં પાસ થઈ અને સાદો વિદ્યાર્થી થઈને આવ્યો હતો અને સુરતે મને સર્જન કરીને પાછો મોકલ્યો. એટલે બિકોઝ આઈ my MBBS at the GMCS, and I proudly a first MS resident of SMEME surgery 2006 to 9, and that always give me a goosebumps while coming back to Surat. Coming back to the academics, you can say there is a traditional science goes as a cycle. Concept that I learned from GMCS, a benchmark that comes later on while you are doing post-graduation, you learn and then become a clinician. But over the years, I realized that there are always a clinician either is an atheist or atheist also. And many times, even surgery means a trauma to the non-surgical medical fellows also. And surgery means a big scar, big stress, and big stress to the family, not only psychological but financial, social, and all these things. But now the time has changed. Surgeries become much more safe, and we believe in a safe surgery. The period of transformation that occurs from open surgery to the traditional laparoscopic surgery, and now I can say it is a robotic Da Vinci system that we are using, that not only scar that is reduced, scar to thik chhe, blood loss, hospital stay, pain, that all we think that have reduced, but along with that vision is quite improved, surgeons fatigue has improved, infection rate are and return to the normal activity to the patients is a big things, and these are all true for all GI surgeries, not pertain to pancreas, whether it's colorectal, esophageal surgery, or common general surgery, or cholecystectomies, or all that things. But now today's my topic is of pancreas, and we learn in our UG days or PG days that eat when you can, sleep when you can, but don't mess up with the pancreas. Even I remember in my PG days, I fondly today remember Dr. Kiran Patki, late Kiran Patki sir, when he was in SMEME, and when once upon time when he does pancreatic surgery, entire surgery department comes in the ORI, whether irrespective of the unit, and stand there to see the how sir is opening. And from there, my interest of pancreatic surgery has developed, and then I pursued further to my surgical gastroenterology, where I did from one of the finest pancreatic center of India and visited abroad also. Why the pancreas is a so scary organ? Because of a pointer chaltu nathi. Pointer is not working. So why pancreas is completely surrounded by the so many important structure of the GI tract, not only tract but blood vessels, reticuloendothelial systems, and everything. You can see the pancreas and aorta IVC is sitting or lying on the IVC and aorta. Just side there is SMV and superior mesenteric artery and all those things. And that's why each and every surgeon is scared from touching the pancreas. And this is true, they are formidable operations because of structures, anatomy is such like that. It's technically challenging, even demanding for the patients, because pancreatic juice, once it leaks, it can destruct anything that comes in front of it. And it is also requires substantial logistic strains to the healthcare and financial resources also. You can just see this, although it looks like spleen preserving distal lesion, just safely I have done, but before transecting this pancreatic lesion, it took almost 4 to 5 hours to reach this stage and just staple and take out the distal pancreas. And it is not like that it is a minimally invasive surgery. It is open surgery is also very challenging task. You can see I am repairing a patch repair of the portal vein where the pancreatic head cancer has already invaded the side wall of the pancreas, and we did the patch repair of the portal vein, and that lead to extreme stress to the not only patients but also sometimes surgeons till patient goes to home. You can see this is the portal vein, and we are doing the patch repair where instead of transecting entire, we kept one wall and then we put the patch. But over the years, the fear of pancreatic surgery has improved because of, and that lead to decreasing the mortality. I know that 20 years back, we just explained to the patient while doing pancreatic surgery that there are 30% chances of mortality, but now with confidently we can say that in our end we can reduce to 2% or less than 2% of pancreatic surgery. But the big question is still that the morbidity because of pancreatic leak and all these things that remains to be evaluated. The last century only pancreatic surgery has improved because of good technique has come up in late 70s worldwide, and technology has improved in the last decade of 20th century or first decade of 21st century, you can say, laparoscopically. And perioperative period, anesthesiology, nutritional management, everything has have their own share of improving the pancreatic surgery. But now what? How we can improve more for reducing the morbidity? It's time to overcome the recurrence of fever, what I can say. In between there was open surgery. Laparoscopy has touched upon the pancreatic surgery for distal pancreas, but complex resections like Whipple operations or duodenal preserving pancreatic resections, or I can say Fraisse procedures, and even distal pancreas, again spleen preserving distal pancreatomy, because many a times spleen is a just innocent bystander we have to sacrifice. Many surgeons in the audience must accept that we have to sacrifice spleen for no reason for pancreatic disease. And all this as laparoscopy has some of limitations that have been robotic approach of pancreatic surgery has reignited. And I know many surgeons in pan-India as well as abroad that they have just switched over from open surgery to directly robotic surgery. They have not done much laparoscopic surgery, but now they are willing to accept this robotic surgery. And we proudly, I can say that Department of GI Surgery at Zydus Hospital, we are one of the first Western Indian center we have imbibed this pancreatic GI surgery program. But it is not like that. Darek loko, everyone has to pass through this skill level and challenge level, from just apathy, boredom, relaxation, worry, anxiety, arousal, and last the flow that comes. When you reach that at high challenge level and good skill level, you can reach that state. But most of the time, each and every medical professional must have passed through this some of the field. And to reaching the pancreatic surgery, we also have passed through that pathway also. Before starting, we just started the basic surgery of robotic like hernias and cholecystectomy. Sometimes it looks funny that that can also be done laparoscopically. Finally, I also agree that hernia and cholecystectomy, still laparoscopy has major role. But to pass over the learning curve and all these things, we did first 3 months because of good support of hospital. We did first 3 to 6 months basic surgeries. Then we reached next level to 3 to 6 months for esophageal and colorectal surgeries. And then we made up our mind to reach the liver and pancreatic procedures to do robotically. The same time, we have to see the world, what world literature is saying. And we can say that we are in 2024, but by the time you can see these methods, August 2008 to 2012. So before 12 years, the USA and already they have published the 250 robotic pancreatic resection safety and feasibility. And now we have ample of evidence and ample of experience. You can see this is for left-sided, or I can get distal pancreatectomy. You can see the numbers of robotic, 100, 200, 200, and now you can say 402 cases that worldwide it's almost acceptable, or rather better survival outcomes in of post-operative pancreatic fistula or major morbidity. You can see is less than in single digit. And same is true for robotic Whipple pancreaticoduodenectomy also. You can see now, you can see the robot open and robotic. I just told that some of the surgeons has just switched over from open to robotic. And just like you can see this open to robotic, lab to robotic. And I know many centers personally in Japan and Korea that now they have stopped doing laparoscopic pancreatic resection. Either they do open or they just opt for robotic centers. But once you see the literature, you have to go to that centers and see the experts. You have to learn from the experts. I fortunate to visit 2 centers at Chicago, where Dr. Melissa Hogg, one of the pioneer of robotic surgery, and Professor Guglianotti was the first surgeon who does robotic surgery in 1999 in the world. At that time, he was an Italian surgeon, but then he shifted to USA. I'm fortunate to have visit that center and could see his fine hands on robotics. And that only you can change the scenario. So, but robot, how it works. This is just a picture I can say from Intuitive company only. But how it works, this is the robotic patient arm. There is 4 arms. We are using Da Vinci, that's why now in market, Indian made, as many robots are also there. You can see how these robotic arms that are clutches over the abdomen, just like laparoscopy, we put the ports and then we attach the arm, and this is the surgeon's console from this robotic microscopic view. This is just like video jockey. We move our hands that lead to movement of these instruments. The surgeon is sitting in this console, just moving the hands while seeing. These are instruments that are, because most of the time એવું કહેવામાં આવે કે હમણાં જ હું આ રોબોટિક ઘણા બધા લેક્ચર્સ લઉં છું. રાજકોટમાં લેક્ચર હતું એટલે બધું પ્યોર રોબોટિક સર્જરી. પછી એક રિસ્પેક્ટેડ સિનિયર સર્જન હતા, રાધર નોટ ઇવન, ઊભા થયા કે તમે રોબોટમાં એપેન્ડિસેક્ટોમીનો પ્રોગ્રામ ફિટ કરી દો, પછી રોબોટ ખાલી કરતો હોય તમે જોવાનું ને. મેં કીધું એવું નથી, ધીસ ઇઝ નોટ ધેટ. રોબોટ 1 સેન્ટીમીટર પણ હલી નહીં શકે ઇફ વી ડોન્ટ ડુ કમાન્ડ. બટ રોબોટિક એપેન્ડિસેક્ટોમી કરવી હોય તો અમારા સર્જનની તો જરૂર પડશે જ. એટલે એવું નથી કે રોબોટ ઇઝ ટેક ઓવર. રોબોટ ઇઝ નો ઇન્ટેલિજન્સ. આમાં એઆઈ છે, પણ એઆઈ સપોર્ટિવ એઆઈ છે. And that is another lecture that someday we'll talk on this. But this is how this robotic system works, that we can say it's very fine tuning, and I invite all of you to visit our center anytime. We can arrange some of the one-time visit Recently, we are by bus or thing, one-day picnic type of you can see and just visit our center to see this robotic surgery. Now the robotic PJ, this is the one, even Whipple resection is difficult and doing the anastomosis is even more difficult. Even in experienced surgeons, I have seen they fumbled even in open surgery. But you can see by robotic, this is our second Whipple around 2 years back. And you can see just how finely we can see this pancreatic duct, that stent, white stent is placed. So we can just have guide, and just like moving the hands, we can do this. One of the most dangerous anastomosis in medical field, I can say, even dangerous than bypass surgery, arterial anastomosis. Surgeon feared from doing this, and you can see by this magnification and ease how nicely without much doing the tissue damage we can do pancreaticojejunostomy. So I proudly say that many of the Indian centers have, gastroenterology centers have not started, or even Gujarat digestive centers have not started this robotic surgery, but now more than 300 GI surgery, along with we reached more than 25 pancreatic resections that includes pancreaticoduodenectomy, distal pancreatectomy, even pancreatic segmental or pancreatic preserving surgery, only enucleation of neuroendocrine tumors, and that we have achieved, and entirely pancreas is saved off from the resection that we have done, and now we have enough experience to do pancreatic surgery robotically. At the same time, outset, I would like to say that now at Zydus Hospital, our department doing more than 1,000 surgeries. Out of that, 60% are minimally invasive surgery, along with high volume of routine surgery with colorectal, pancreatic, and we are doing almost last 2 years more than our department, more than 100 robotic surgeries per year consistently we are doing. At same time, we can be recognized at global level. Last year, Japanese Surgical Society has given me this travel grant for developing pancreatic surgery. Same time, I visited UK to show off our experience of robotic spleen preserving distal pancreatectomy. And the team, it cannot happen. My senior colleague, Dr. Bhavin Patel, is also GMC Asian, is fondly remember this, Surat. And this is our last patient, 78-year-old industrialist, flight from Pune for robotic Whipple pancreatectomy. And within a week, he was discharged. And this is without team, we cannot perform or we can reach this level. Thank you very much for doing this. I'm happy to take some of questions if time allows, otherwise already we are late, I think so.
But thank you very much for your comprehensive overview. As such, pancreatic surgery, open pancreatic surgery, before few years it is a very supra major. So from open to laparoscopic to the robotic, it is showing the real progress of the medical field in India in the last decades, we can say. And how ease it is doing, or we are seeing that how with each ease it is done, and with what minimal blood loss. Believe me, it is directly proportional to like your dedication, how many hours you have spent in the OT and in the operating room and during the surgery over the years. So it is really remarkable, and thank you very much. Thank you very much, sir.
Thank you.
I will request Dr. Hiren Makwana and Dr. Ketan Jagirdar, please to felicitate Dr. Daivat Vaishnav, sir.
How much